Okay, great. So I am presenting on some data that Steve and I were just looking at. And for those of you who don't know me, my name is Kaitlyn Browning. I'm a new postdoc here with Steve Higgins. So we were interested in looking at measures of nicotine dependence severity and how those were related to actual nicotine intake and the relative reinforcing value of nicotine as measured by a demand task. And the reason we were, you focus on these measures of nicotine severity is because we do know that they are one of the strongest predictors of subsequent cessation. And we were more recently getting a bit interested in the Wisconsin Inventory of Smoking Dependence Motives, and kind of boiling that down to the particular questions that were related to these other dimensions of nicotine use that we were interested in, and compare that simultaneously along with a more commonly used assessment, the Fagerstrom. And so ultimately what we did is, using multiple regression, we just looked at individual items of the wisdom and individual items of the FTND, and wanted to know what specific questions significantly predicted actual nicotine intake, which was measured by some cotinine and 3-HC. We got it down to 5 questions from the wisdom out of, initially it was 16, I believe, 16, because we only used the primary subscale of the wisdom, which I can go into more detail if someone is interested. 2 of the Fagerstrom items, which were the heaviness of smoking items. And we then wanted to know, how did those items relate to, of those items that predict actual nicotine intake, how did those relate to the relative reinforcing value of nicotine or of cigarettes, as measured by the intensity of demand under when unconstrained by price, and also how demand is impacted under escalating price. So those 2 measures of nicotine demand. And you'll see in this table here, we ultimately ended up with the 5 items that predict intake, 4 that predict amplitude, which is a measure of a latent factor of demand intensity, and then only 2 for persistence. And this wasn't terribly surprising, because we generally know, or it's been demonstrated, that amplitude is a bit of a stronger player when relating it to nicotine dependence. And what I think was interesting is that from all of these items, we boiled it down to these 5. And what these 5 items ultimately tap into is how heavy of a smoker the person is, and how much they feel like they've lost control over their smoking. And those sort of constructs seem to be important. I have no idea how long that was, but if I can answer any questions, since I kind of just breezed through it.
You're good. It was like 4 minutes.
Perfect.
All right, so we can take a question or 2 then. So what did you see differences when you were looking at consumption under unconstrained by price as compared to the escalating price? Where was the strongest effects?
That's the difference between amplitude and persistence. So amplitude is the demand for cigarettes when unconstrained by price, and persistence is kind of the rest of the demand curve indices boiled down into into amplitude versus persistence. Ultimately, what you can see, especially if you look at this summary here, model B for amplitude as compared to model C for persistence, amplitude is driving the show a bit more in terms of, this relation here between amplitude and nicotine severity is stronger than it is for persistence. Does that answer your question?
Yes, you're saying the demand and the dependence indices are more strongly associated with the amplitude measures than with the persistence measures.
Exactly, yes. And that's also the same with actual nicotine consumption. I don't have those data here, but that has been previously reported too. So amplitude is kind of amplitude, dependent severity, and actual nicotine intake are all sort of together as like particularly important dimensions that we need to be paying attention to.
All right, very cool.
Elisha, I think you're next. Oh.
Yes, thank you.
Awesome. It looked like you were pulling it up, but I just wanted to make sure you knew.
All right, is that visible for everyone?
Yep.
Awesome. So for those of you who don't know me, I'm Elisha Lepine. I work here at the CBH with Julia and Dr. Andrea Volanti. And I'm presenting today on how youth and young adults define addiction in their own terms, which is an analysis of qualitative data collected during Wave 2 of the PACE Vermont study. So prior research in secondary prevention shows that mass media campaigns can be effective in preventing substance use in youth and young adults, but that prevention messaging targeting addiction-related themes lags behind messages targeting harm-related themes in effectiveness. So we wanted to know how youth and young adults describe addiction in their own terms in order to better fine-tune prevention efforts in the future in Vermont. So data for these analyses come from Wave 2 of the Policy Communication Evaluation Vermont study, which was a statewide survey of substance use in Vermont youth ages 12 to 17 and young adults ages 18 to 25. 1,185 participants participated in Wave 2 of the study, and 1,149 participants responded to the item, the open-ended item, what does addiction mean? I, along with my co-author Kaitlyn McCluskey, reviewed all of these responses and started to develop inductive categories to capture the common themes and constructs among them. And we developed a system of 3 major categories and 15 subcategories to capture all of the themes. These responses were independently coded by myself and by Kaitlyn. We assessed intercoder reliability for each category using Cohen's kappa. So our participant demographics you can see here in table 1 on your left-hand corner. And the full list of coding categories is here in table 2 in the middle. The 3 major categories that emerged were physiological changes, psychological changes, and behavioral changes. So participants generally characterized addiction in terms of at least one of these domains. The most common of which was physiological changes. So participants often mentioned experiencing addiction or understanding addiction as some sort of physiological dependence on a substance. The next most frequent category was psychological changes. And within this, the 2 subcategories, psychological need and self-regulation, were the most common subcategories. So examples of these would be saying addiction means that you need something to get by without any specific sense of physiological role in that need, or you don't have any control over your use, or you can't stop, which would be coded as self-regulation. And the Third major coding category was behavioral changes. So this is when participants identified some kind of change in a person's behavior due to their addiction. And this included changes to everyday functioning, changes around seeking out the substance, and changes to social relationships. Figure 1 illustrates the overlap between categories. So categories were non-exclusive, such that multiple categories could be applied to a single response. And the greatest area of overlap was between physiological and psychological responses. Behavioral responses were shared almost entirely. There were very few exclusively behavioral responses, and very few what we would call holistic responses, which were those which could be categorized at least once in each of the 3 major categories. And this tells us that there's ample room to enhance youth and young adults' understandings of what addiction means for them. And in particular, enhancing their understanding of how addiction can impact their relationships and their functioning in daily life, which is some of the less common subcategories referenced. In general, these data tell us that young people tend to conceive of addiction largely as a matter of physiological dependence, either caused by or resulting in a failure of self-control. So the popularity of the self-regulation subcategories still tells us that there's an element of, we see often people responding that it's a matter of just not being able to choose to stop. So there's still some amount of potentially blame or stigma being attached to addiction. Analysis of subcodes across all major categories also reveal that our sample was far more likely to frame addiction as a matter of individual perception, choice, and self-control, and very unlikely to frame it as a disorder or a medical condition. So in terms of messaging recommendations, the popularity of the physiological and psychological codes and sub-themes may be areas in which messaging can focus in order to harness already resonant themes with youth and young adults. And we also recommend that the less referenced subcategories like behavioral changes and especially relationship changes be targeted in order to produce messages that are more novel and educate young people in a more broad and holistic understanding of what the real consequences of addiction are. I think I've probably gone over time.
Well, that was great. And I'll just ask you one quick question then. So do you think that the effective or the lack of effectiveness of messaging around addiction is more due to addiction not being couched in the terms that the young adults understand it, or just that the young adults have perhaps less experience with the physiological fallout of addiction because they're younger?
Yeah, I think that there's a combination of factors. We know from a recent, I want to say, Rodenitis et al. Found that messages targeting addiction were often perceived in young people in focus groups to sort of be unrealistic or just not that pressing. So there's a factor of consequences of addiction not feeling present and concrete. And I think by understanding what young people believe addiction actually means, we can better illustrate to them the immediate and concrete effects of addiction. Does that answer your question?
Thank you.
I was just going to add, Diane, to that, what Elisha just said. We've also seen that the most effective messages that target addiction are messages that do have like kind of harness those like acute effects of addiction. So like this idea that addiction might prevent you from being able to spend time with your friends or might affect your interpersonal relationships and social life, those have been more effective than sort of those like less immediate, more abstract ideas of addiction. So it's kind of like what Elisha was
socially oriented, color me
what?
surprised. You said you're saying they're steep discounters that are socially oriented. Color me surprised.
Yes, and just to build onto that, one thing that stood out for me from the very beginning was just the paucity of responses in relationship changes in that subcategory. And I think we know that young people care about their social relationships. They want to have meaningful engagement, but for some reason they're not making the connection between my addiction might mean not connecting with people. So I think that's an area that's ripe for messaging.
Yeah, and one of the big this is what I'm doing my master's thesis on, but one of the big implications of this is that the Real Cost campaign has shifted from harm and addiction related messages to just addiction related messages. So our largest, like most funded prevention campaign in tobacco is focusing on addiction related messages with evidence to say aren't as effective and clearly real conceptions, understandings of what addiction really is and means from this study. So it's really exciting, cool stuff.
Very nice. All right, let's shift gears. Bring it, Will.
All right, you all see this?
Yep.
Cool. So in keeping with the theme of virality, I wanted to look at some measures that are commonly associated with virality, despite my area of research not really having a lot of direct measures in the cardiac rehab program of virality. So for those of you who don't know me, my name is William Middleton. I'm an experimental psychology grad student in the VCBH, working under Dr. Galima, primarily in the UVM cardiac rehabilitation program. I'll be presenting fitness benefits in cardiac rehabilitation between sex and education. Women in rural environments tend to have lower levels of SES factors associated positively with increased health compared to men and their urban counterparts. Education is a prime example of a factor associated with positive health, in which women are disadvantaged. What is especially concerning is that the health benefits which are conferred by factors like education are less pronounced in rural women than in men. Cardiovascular health, specifically recovery from an adverse cardiac event, may be an area where we see lower conferred benefits in women, especially considering the history of literature. The University of Vermont Phase 2 Cardiac Rehabilitation Program is such a program where we need immediate action to induce positive behavioral change to reduce cardiovascular disease-related mortality. A primary means through which cardiac rehabilitation reduces mortality is by increasing cardiovascular fitness through giving out nutritional education and guiding patients one-on-one with some sort of caregiver, a doctor or a, I've been having an issue with my internet. A primary means of measuring health improvement throughout cardiac rehabilitation is through assessing aerobic capacity. Aerobic capacity is estimated through asking patients to perform an exercise test, then measuring their maximal volume of oxygen uptake during the stressor. The result is VO2. In this project, we examined the relationship between sex, education, which is a well-validated demographic marker of SES, and we're looking at SES as an indicator of one of the prime health issues with women in rurality. On the fitness benefits yielded from cardiac rehabilitation in terms of VO2 within UVM's CR program. The set of hypotheses were that, consistent with prior literature, women would observe lower VO2 improvement than men over the course of phase 2 cardiac rehab. Lower education would also be associated with lower fitness benefits, and that women with low education would improve VO2 less than even low education men. We included a total of 490 patients, roughly 23% were female. ANOVA was tested to detect differences between sex and education levels on fitness improvement. Follow-up hierarchical multiple regression was performed to identify interaction effects between sex and education. Men and women did not significantly differ in years of education completed, with a mean difference of less than half a year of educational attainment between them, which is 14.92 years of education for men, only 14.55 for women. That's not very much, it was not significant. This may be due to the fact that UVM MCCR program samples from a diverse geographical area, and our data did not directly account for that rurality. We generally see an educational difference between men and women within rural samples. Level of educational attainment also did not significantly account for variance in fitness improvement. We did find that women improved significantly less than men in general, though. Women improved by an average of 67% as much as men. That's 2.29 milliliters per kilogram per minute of oxygen uptake, VO2, against an uptake of 3.41 in men. Sex explained only about 2% of that variance. This effect persisted after accounting for education. However, there was no interaction effect that was significant, and it only accounted for 0.1%. So ultimately, those results paint a modestly positive outlook for women with cardiovascular problems. Although they do confer less fitness advantage from cardiac rehabilitation than men, which some research attributes to increased age or onset of cardiovascular problems, this effect is not compounded by an interaction with educational attainment. The study did not have a direct measure of virality. Future research should index cardiac rehab patients via their address to truly assess those rural factors.
All right. I'll let Phil ask a question.
Yeah. Well, first observation is that I'm an author on this, and this is the first I've seen it.
Yeah.
Which is a little unusual. What was your hypothesis going into it? So you thought that women train less than men, and that maybe we could explain it by education, but they weren't different in education, so that doesn't explain it.
So the idea, and I kind of boofed on the intro to this, and I'm sorry about that. I was having some internet difficulties with some of my notes. The hypothesis was that women, we see that women get less conferred benefits from SES markers of health than men, even when they do have equal markers, like things like their financial state or their education tend to be predictors, less strong predictors of, you could say, resilience or not getting some sort of health problem. So the idea was, within cardiac rehabilitation, women with equal education to men would receive less benefits, that there would not be an interaction between education and sex on the amount of VO2 improvement they have throughout cardiac rehabilitation.
Okay, because I could see more that I would fully expect education to be a predictor of fitness entering cardiac rehab. But I've not seen anything that it would alter your ability to train. You know, and if you think back,
possibly is that the educational attainment is reflective of other SES, other behaviors that go on with SES. So
yeah,
like
someone who's lower SES, they might be doing other things outside of CR that would impact their ability to improve.
such as smoking?
Or just how much they exercise outside of CR.
Mm-hmm.
So when I was looking at a lot of the SES markers of virality, since the theme was virality, I decided to extend that and look at education, which is really big difference between people we see who are rural and people who are urban. The idea being that I saw a decent amount of positive buffering going on by education in the literature that I looked at for health effects, and wanted to see if that was an area, if improvement in CR was an area in which education buffered differently depending on sex.
I mean, had I seen this before, I would have said something like, gee, we have zip codes for all of our patients. And if you're 04501, you're in Burlington. And if you're whatever, you're in Virgins, and that's pretty rural. You know what I mean? Like there are some ways we can get at rural.
Yeah.
But anyway, so your conclusion is kind of a negative one, that differences between men and women in training exist, but they're not explained by differences in education.
Yeah, we didn't find any effect for that. So there are, we know there are sex differences in improvement in cardiac rehab, but there was no significant effect that it was mediated by education.
Yeah. Okay.
All right.
You ready, Sherrie?
Let me pull it up.
Sorry, Diane, I feel like I'm dropping the ball, but my internet keeps cutting out.
That's fine. I'm around. I can't help myself anyways.
Yeah. Well, I'm glad you're here, because I only got like every other word that Will just said, so.
Maybe that was.
Am I good to start? Sorry.
Yep. We see the poster. Take it away.
Hi, for those who don't know me, I'm Sherrie. I'm one of the cardiologists at UVM and an assistant professor of medicine at the Lerner College of Medicine. So what I'm going to be sharing with you today is a project that I looked at funded by the COBRA that's examining what are predictors of cardiac rehabilitation participation. And just to take it one step back for those who are a little bit unfamiliar with the program, so cardiac rehab is actually an outpatient-based program that focuses on lifestyle management as well as exercise for cardiac patients. So specifically patients who've had a recent heart attack, had a stent placed, underwent bypass surgery, and so forth. They are referred to this program, which has been shown to not only reduce mortality, but has examined effects on improving quality of life as well as exercise capacity. And so really the goal is to give the patients kind of a framework so that we can prevent a recurrent cardiac event from occurring. And so one of the things that we realize is that unfortunately, overall, that the program tends to be underutilized. So looking at the Medicare patients, it was only utilized anywhere between 19 to 34% of those entering cardiac rehab. And the reasons for this really vary from anywhere between some of the psychosocial behaviors. So for those who have maybe depression, anxiety could be a potential barrier, all the way down to depending on what their diagnosis is and whether or not they have social support, et cetera. In the past, the literature has sort of been more reflective of retrospective, small analysis. And so one of the things that I wanted to look at was to really do a more in-depth prospective observational study that would kind of really assess what are the demographic, medical, and psychosocial factors which would influence cardiac rehab participation, and sort of go a little bit further into what are maybe perhaps the differences between men and women. And so what this entailed was we approached patients who were eligible for cardiac rehab who were hospitalized after a cardiac event. And patients who qualified for the study were approached in the hospital. And if they acquiesced to participation, we performed in-depth questionnaires. And so, for example, the ones that you'd be familiar with is the GAD-7 that would screen for generalized anxiety, PHQ-9. We also did the brief questionnaire, which would assess executive function and also gauge what their social support was. And so when patients were enrolled in the study, they were told that this was a study that was looking at how you recover from a cardiac event. So they did not realize that this was anything to do with cardiac rehab participation. And what we would do is we would then follow them to see, which patients actually went to cardiac rehab. And then for those who did not participate, would inquire 3 to 4 months after their hospitalization as to what those potential barriers for non-participation were. And so we enrolled 294 individuals, 31% of that were female, and of those patients, 60% actually participated in cardiac rehab, and I would say that that's very much a reflection of the strength that our program has overall, and so we're a little bit out of the norm compared to other programs across the country, but it's still something that we could do better. The average age was around 68 years of age, and if you look at sort of the results, what it shows are what are the different predictors and factors as to the correlates for cardiac rehab participation. And so looking at the list, you know, one of the major factors that we found was having the use of an electronic referral. And so what this means was when the patient was about to be discharged, whether or not you actually placed that discharge order for cardiac rehab really did influence as to whether or not a patient would participate. And additionally, patients who were a non-smoker, who had a higher level of education, who had better social support, as well as a better self-reported physical function, were more likely to participate in cardiac rehab. Another factor that we looked at was the strength of the physician recommendation. This was something that was looked at in 1992 by my mentor. You know, what is the power of your healthcare provider recommending cardiac rehab? And you know, 20 plus years later, that still holds true as to the patients really looking for guidance, whether it be from the physician or the mid-level provider or a resident, to really emphasize the importance of going to cardiac rehab and saying that this is part of your treatment, just like taking a medication such as aspirin or statin and so forth. And so when you really looked at what are the specific independent predictors, you can see that the list is quite long, but really the main independent predictors were the electronic referral, the surgical diagnosis, so meaning those who had a bypass surgery or valve surgery, being a non or former smoker, as well as the strength of the physician recommendation were independent predictors. And really there weren't any different submeasures that were seen in regards to anxiety, depression, or executive function. And I think that's quite important to note because it differs compared to the prior literature. And specifically, what's not shown here is that we kind of further used a CART analysis to kind of create these risk profiles, like which patients would be more likely to come to cardiac rehab. And what we found that males who had an electronic referral to cardiac rehab, high school education or higher, who had a heart pumping function known as the ejection fraction greater than 50%, as well as a strong physician recommendation, that was the most likely cohort to participate in cardiac rehab. And those who did not actually receive the electronic referral were the least likely to attend, with only 20% attending. And so sort of what this means in, you know, looking at the future direction, it's clear to see that those with lower education as well as smokers are our most vulnerable population, and those are the ones who are least likely to go to cardiac rehab. And specifically when we asked patients, you know, why didn't you attend cardiac rehab, they had cited that the lack of interest was one of the reasons why, as well as transportation issues. And so it's really challenging us to think of what are ways that we can, engage the patients for coming to our program. But for those who really live out in further rural areas, how can we create perhaps a hybrid program or some type of system to make sure that they get the preventive care that they need? So that's all that I have.
Speaking of transportation issues, so did you look at distance to the program as one of your predictors?
Yeah, so in regards to actual zip code, no, but all of the patients who were referred that I examined were where our center was the closest to them. And so meaning that they had to live in Chittenden County or Addison County.
But we still have some variation in how far people have to travel to get to the clinic. So
absolutely, yeah. But like breaking that down as to those, patients, because it was like 97, probably like 110 patients where their zip codes were, that wasn't further analyzed.
Yeah, we have done that in the past, and time to travel, even within 45 minutes, is a factor, as you can imagine it might be. One thing I'd like to observe that's interesting is Dr. Schopfer earlier today mentioned that when they asked people in the VA system in California why they didn't go to cardiac rehab, 40% of them said something like, never heard of it. Or some big percent. I don't know if it's 40%. I think we've just about gotten to the point where with our automatic referral, and people get handed this when they leave, just about nobody's going to say, hey, I never heard of it. I like that. I like that. One observation question or another observation I have is your introduction said 19 to 30%, 34% participate in cardiac rehab. Those are kind of old data, and they're also data from Medicare, where your analysis has been all ages. But in fact, our program, remarkably, I love it, 60% participate. How relevant are our data to non-Burlington, Vermont programs? How relevant are they in, I don't know where, upstate New York, Nebraska, New Mexico, where they might have a 26% participation? Do you think it's a whole nother set of factors, or do you think it's still going to be, do you have an electronic referral? Did your doctor tell you surgical diagnosis? Do you think those are going to be across the board, or do you think there might be a gradient depending on how good you do with electronic referral and how well known your program is and so forth?
Yeah, no, I think that's a great question. So I think there's certain factors that would be applicable to any center. One for sure being the use of electronic referral. We know that that's a huge major barrier that's been studied in other areas, where just having that alone kind of puts you on the radar, allows the patient to know about the program. So that's sort of hopefully your ticket to the door, so to speak. I think when it looks into what makes our program unique and what I would hope that people would see, like, what are we doing in our program that's strong that could be replicated at other institutions, going back to something as simple as the strength of the physician recommendation, something that we can show that we are spending the time to educate and tell the patients and provide that counseling, that maybe that's not being done in other programs. And so I think having sort of a look as to what are the specific vulnerable population, and that can vary from, you know, one program to another. So for us, like, yes, we're rural, that tends to be barriers versus if you're in New York City, you know, you have those programs, but it's just still so challenging for you to get there. It's such a populated area. And so I think the take home message is really, what can we identify in certain things that can be replicated?
Yeah, I mean, so many of these predictors do seem to be replicable across different situations and different studies. And I don't think that a surgical diagnosis here is going to be different than a surgical diagnosis elsewhere, because there's still that, hey, you're in the hospital, you had your chest cracked open, you have to be here for a couple of days, this is serious, you almost died business. That message is still going to be there regardless of where you are. But I get your point, Phil, but I definitely think that other things like transportation might be a bigger barrier in a place where the distances between centers are larger. Or, you know, or maybe, you know, smoking may be a barrier in places where smoking rates are higher, but the level of predictiveness of smoking may still be the same. It just may be a bigger proportion of people there that are doing it.
One other observation is that for the longest time here, I knew that the physician recommendation was a very important thing. I was frustrated that even when I was on the CCU service, I didn't always have the time to speak to every patient, because you're, as Sherrie knows, you're running around like crazy, signing notes and so forth. I think a major breakthrough might have been when we have the electronic referral, and it says right up there that you're referred to cardiac rehab if you have any of these diagnoses, and opt out if you need to opt out. I think all of a sudden the fellows are saying to themselves, shit, I better learn a bit about this kind of stuff. They're making me do it. It's just like if they're making you give aspirin, well, you darn well are going to look up the studies to say, oh, does aspirin really work, or statin or whatever. So I think force feeding it into the system, I think in and of itself was a teaching intervention for physicians. And in many cases, it's the fellow who the patient might know the best. You think the attending signs all the notes, he's the big honcho, he or she. But I think in many cases, they know the fellow the best because they're coming in and out all day. And if the fellow and the resident need to refer to cardiac rehab, well, they better talk it up. You know, it's interesting that you don't know, is chicken or the egg kind of thing.
Right.
That's funny. They must have thought it important enough to put it on the farm.
Yeah. well, Sherrie forced it on there, but it's a class 1 recommendation of the AHA. I mean, it's right up there with everything
Someone
else.
had to think important enough to force it on
Yeah.
that form. So that's
Yeah,
a very
helps to get the
interesting point.
chief of cardiology to buy in. Anyway.
Well, I think that's actually our time at this point, which I really did enjoy the opportunity to actually see some people and have some back and forth about it. So, but remember, there's another set of sessions in 15 minutes. So I hope you guys join one of the afternoon sessions. I'll be chilling over in marijuana.
It's gonna be a party.
I'll be
But thank
chilling
you guys. And thank
chilling
you
on the
for doing your
elliptical.
research, and enjoy the rest of the conference.
Take care, guys.
Bye.
Nice job, everyone.